Hey, physiology peeps. Welcome to lecture 2 of chapter 7 and 8, cardiovascular and blood physiology. So let's get started. Okay. Last time we'd covered a lot of things about the heart. We talked about heart anatomy, the heart conduction system, using an EKG to measure the heart's conduction system. And then we talked about arrhythmias like tachycardia and bradycardia, in addition to what regulates the heart's pacemaker. So today we're going to start with blood pressure. So, blood pressure is one of the regular things you're going to do as nurses or healthcare providers when a patient comes into a clinic or a hospital. You're going to measure their blood pressure. Now, we talked about ventricular systole and diastole in the previous lecture, but now let's talk about blood pressure. That is the pressure of arterial blood against the vessel walls. And when the heart goes through a cardiac cycle and the ventricles contract, they press oxygen rich blood through the arterial circuit under pressure, and that pressure can push against the artery walls, and that pressure can actually be measured with a blood pressure cuff. So, the systolic blood pressure is the pressure that is resulting from ventricular contraction. And so, when you measure blood pressure, that's the numerator or the number that's on top. The normal arterial blood pressure range can be 80 to 160. That's what your body's kind of normal range is. Anything below that is considered an emergency. Anything higher than that is considered an emergency to your body's regulatory system. Diastolic blood pressure is the pressure you record when the ventricles are relaxed and filling with blood, and that'll be the denominator or the lower number. Okay, so when you're measuring blood pressure with a manual blood pressure cuff called a sphygmomanometer, you place that cuff over the arm, the biceps of the arm, and then you have a cord that goes to a pressure gauge that has a bulb that you can fill the cuff with air. There's also the gauge where you can actually read the blood pressure. Now, in conjunction with the sphygmomanometer, you have a stethoscope because you're going to actually be listening to sounds that are coming through the brachial artery, shown here in red. Okay, so that cuff goes over the arm, and deep inside that arm is the brachial artery. So, we're going to go through the process of how you use a manual blood pressure cuff. You have the patient sitting with their legs relaxed on the floor. Their legs can't be crossed because that would impede venous return of blood to the heart. So their legs must be just flat on the ground. And their arms should be on a table somewhere at the same level of their heart. You put the blood pressure cuff on, and when it's in place, you turn the dial, not the dial, but the knob on the blood pressure bulb to the closed position. Usually that's righty tighty. And then you start squeezing the bulb so that air starts being filled in the cuff, and the cuff expands. And when it expands, it is going to, when you get that cuff up to 160, 180 millimeters of mercury on the gauge, that cuff should be pretty tight on the arm. And what it's doing is it's actually temporarily cutting off blood flow through that brachial artery. Now, what you're going to do is you're going to put the stethoscope at the base of the biceps, right about there, and you're going to have the stethoscopes in your ear. And what you're going to be listening to is sounds. So you slowly turn that little knob on the bulb a little bit to the left to allow air to start escaping slowly from the cuff. And you're going to be listening with the stethoscope. And what you're going to be listening for is you're going to start to hear sounds come through that artery. As the air escapes the cuff, it is releasing pressure on that artery. The artery is starting to open up and allow blood through. And if you're listening with the stethoscope right here over the brachial artery, you'll start to hear the sound of that blood going through the artery. And when you first hear sounds coming through, you look at the pressure gauge and you write that number down. That's going to be the systolic pressure. You keep listening, and the sounds called Korotkov sounds, the blood sounds, get a little bit louder, and then they start to fade. And when the sounds completely go away, you look at the gauge and you write that number down. That's the diastolic pressure. When the pressure has gone away, what is happening is the cuff has released so much that the artery is wide open and there's no more resistance to blood flow through it. And so you don't hear the sounds. So we're going to listen to a YouTube video of the Korotkov sounds. Okay, let's make it big. That was the sound starting. Keep listening. It gets a little louder, and it's going to go away. Okay, let's do that again. Okay, I'm going to tell you where the systolic blood pressure is and the diastolic. So listen carefully. There. That was the systolic pressure. Gets a little louder. See how the lines get bigger? Keep listening. Okay, that was the diastolic pressure where the sound went away. Okay. Okay. So here's a diagrammatic of what looks like. When you puff up the blood pressure cuff maximally, the brachial artery gets closed, and there's no sounds because the artery is closed and the blood can't move through. As you slowly release the pressure on the cuff, it starts to allow that artery to open up, and you'll hear those sounds start like you just saw in the video. That first sound is called the systolic pressure when you look at the gauge. Now, as you keep listening and the cuff keeps deflating, eventually the artery will open up wide and the Korotkov sounds will go away. That is going to be the diastolic pressure when you look at the gauge. Okay, so now we're all experts at measuring blood pressure, right? Okay. Well, let's talk about, in addition to blood pressure, let's talk about cardiac output. This is something you measure in someone where you're determining if their heart is functioning correctly. There are many pathologies that can result in the heart not acting as an efficient pump. And so cardiac output is the milliliters of blood that leave the heart every minute. And cardiac output is a mathematical formula of stroke volume times heart rate. Well, you know what heart rate is. That's the beats per minute of your heart. But stroke volume is with every beat of the heart, with every cardiac cycle, it's the volume of blood that is ejected from the heart. So that's the mLs for every cardiac cycle, every beat. If you multiply that by how many times your heart beats in a minute, you get cardiac output or milliliters of blood every minute. The average heart rate can vary a lot, 60 to 180. Average stroke volume averages 70 to 80 mLs with every beat. And if you multiply those out, you get to an average cardiac output of 5,500 mLs per minute or 5.5 liters per minute. All right, 5.5 liters. That's a lot of blood to pump out every minute. Okay, so there are many things that influence cardiac output, and I've got 6 here, but this is not all the things that can affect it. But heart rate and stroke volume definitely affect cardiac output. In fact, stroke volume and heart rate are in the mathematical formula to calculate cardiac output. So since it's a 1-to-1, as stroke volume goes up, cardiac output would go up. If you increase heart rate, cardiac output would go up. If you decrease either one of these or both, cardiac output would go down. Okay, the next thing that affects cardiac output is end diastolic volume. Okay, and then we'll talk about each of these subsequently. So let's just look at things that affect heart rate. Okay, obviously, if heart rate is part of the calculation for cardiac output, if heart rate goes up, cardiac output goes up. If heart rate goes down, cardiac output goes down. Now, heart rate, reviewed from the first lecture, can increase with sympathetic stimulation or decrease with parasympathetic stimulation. Now, pharmacological drugs that can influence heart rate and thereby influence cardiac output. Well, epinephrine, if it's sympathetic stimulation and epinephrine binds to the beta 1 adrenergic receptor on heart pacemaker cells, heart rate's going to go up, and that's going to drive cardiac output up. Digitalis, we talked about digitalis as a drug to increase the contractility of the heart in people who had bradycardia. So it increases calcium that's available to the heart, and that will increase the strength at which the heart contracts with every heartbeat, and that will increase cardiac output. If you make more epinephrine available in the body by someone who's on an MAOI, monoamine oxidase inhibitor of the class A, that's an agonist to epinephrine, and so that would increase heart rate. And lastly, if someone was on dobutamine, that's a beta 1 adrenergic agonist that makes the heart beat faster. that will also increase cardiac output. Now, conversely, drugs that will bring cardiac output down are drugs that can decrease heart rate. So, our general beta blocker, propranolol, can do that. The specific beta 1 blocker, which blocks just the beta 1 adrenergic receptor, atenolol, can do that. And then you can also, instead of blocking the receptor for epinephrine, you can simply block the sodium and calcium ion channels on pacemaker cells so that even if epinephrine's present, it can't open up those ion channels, and that makes heart rate go down and cardiac output go down. Okay, so we covered heart rate. Now let's look at stroke volume. Okay, so it's a direct proportion. As one goes up, the other goes up. As it goes down, the other goes down. So stroke volume is affected by how hard the heart muscles contract when they contract. So heart contractility is the strength of the contraction of the heart. If the contraction strength goes up, stroke volume goes up, and that makes cardiac output goes down. The opposite is also true. If contractility decreases, stroke volume goes down, and so does cardiac output. So everything we've talked about so far is a direct proportion. As one goes up, the other goes up, and if one goes down, the other goes down. So, done with heart rate and stroke volume. Now let's talk about end diastolic volume. End diastolic volume is the volume of blood that's in the ventricles when they're relaxed and filling with blood. So during ventricular diastole. This, how much blood is in the ventricles, is determined directly by the venous return to the heart. So remember, veins are traveling all the way back to the heart from your feet to your arms, all the way back to your heart. And I've got a little pie chart here that shows you rough approximations of where blood is in your body. And most people think it's in your arteries, and it isn't. Most of the blood at any point in time resides in your veins. So getting venous blood back to the heart affects how much blood can be in the heart. And so venous return is important. If venous return is impeded, then less blood can fill the ventricles. If venous return is improved or good, more blood can fill the ventricles. Now, you might have wondered why astronauts or jet pilots have to wear tight suits, especially around the legs. It's because when they're being pulled up at incredible g-force, the force of that gravitational pull wants to pull blood down from your head and neck and below your heart, making you prone to passing out. The tight suits, especially around the legs, helps push venous blood back to the heart. It prevents that blood from pooling down in their extremities. All right. So, venous return. As venous return is improved, end diastolic volume is improved, more blood fills the ventricles. That will increase cardiac output because there's more blood there to contract out. If venous return is diminished, then end diastolic volume, or blood in the ventricles, goes down and cardiac output goes down. So, all right, venous return is important. Remember how in the previous lecture I was talking about blood pressure? Well, actually, this lecture. And I said, when you're measuring a patient's blood pressure, their legs must be, relaxed, feet on the ground. You can't cross your legs, all right? Want to know why you can't cross your legs? Because the weight of one leg on the other is going to impede venous return of blood to the heart. So the veins in those legs could be compressed and slow down venous return. That can affect your blood pressure reading. That is affecting cardiac output. Okay, so another concept here is you must have roughly the same amount of blood in your venous system as is pumped out through the heart. It's an equal ratio. So arterial blood must match venous return. Okay, that's just a concept. Okay, moving on. Now we're done with end diastolic volume. Let's talk about stretching of the heart. If more blood returns to the heart as venous return, the ventricles will fill more. Well, muscles have this strange thing that the more you stretch them, when they contract, the harder they contract. All right. And so the more blood that fills the ventricles, it's going to stretch those ventricles. And when they contract, they're going to contract stronger. So the Frank Starling law is, I like to think of it as the Frank Starling stretching law of the heart. As you get more venous return, the ventricles get stretched. When muscles are stretched, including heart muscles, when they contract harder. And if contraction strength goes up, cardiac output goes up. And the opposite is true. If less blood returns to the heart, the ventricles won't stretch as much or at all, and the strength of the contraction of the chambers will go down and cardiac output goes down. All right. Now, let's talk about the last factor. Everything I've talked to up until this point, stroke volume, heart rate, end diastolic volume, stroke volume, okay, and the stretching of the heart. All of those are direct proportional relationships. As one of those factors goes up, heart contractility goes up. If one of those factors goes down, heart contractility goes down. The arrows go in the same direction. Total peripheral resistance does not follow this. It's an inverse relationship. As one goes up, as it goes up, cardiac output goes down. As it goes down, cardiac output goes up. So imagine this resistance. It's the resistance of blood flow in the arteries. It depends on how thick that blood is, basically the water content of the blood and what particles are dissolved in the blood, and also the vessel length and its diameter. Okay? So think of this. You have a long tube, all right? Plastic tube. You have a syringe of water that you connect to that tube, and you depress the syringe and the water goes flying through the tube, right? No resistance whatsoever. Water, pure water, doesn't have anything dissolved in it. Now, let's try the tube experiment with a syringe full of corn syrup. You hook that syringe up to the tube and you try pressing that syringe to push the corn syrup through the tube, and guess what? That corn syrup is thick. It's got a lot of resistance. That would be like thick blood, and it has a lot of resistance going through that tube. And the longer the tube is, the more resistance you have. So think of it this way. If someone has blood that is very viscous because they're dehydrated or they've got a lot of proteins or albumins dissolved in it, that blood is going to be relatively thick. The resistance of that blood moving through the blood vessels like a plastic tube, the resistance is going to be very high. And so the heart has to work harder to contract and eject blood that is thicker in nature. So as resistance goes up, cardiac output goes down because the heart has to work harder to move viscous blood than more watery blood. So if that blood was not very thick, the person had a normal amount of water or plasma in that blood, the resistance of that blood would be lower, okay? Something a little more concentrated than water, but much less concentrated than like corn syrup. So that is going to have less resistance. All right, that's going to be easier for the heart when it contracts to eject that blood out. So cardiac output will go up. All right. All right. So let's look at all of these things together. Notice that as heart rate goes up, cardiac output goes up. As it goes down, so does cardiac output. In fact, if you look at each of these factors, stroke volume, end diastolic volume, stretching of the ventricles, if one arrow is going up, cardiac output's going up. And if that other factor is going down, cardiac output is going down. But for resistance, it's inverse. One arrow is going up, cardiac output goes down. If resistance goes down, cardiac output goes up. All right. All right. That's a good place to stop for lecture 3. I'm sorry, stop with lecture 2.